Kia ora, thank you. Thank you for putting me after Harold and Tuari, two of the greatest orators that I've ever seen, so thank you. But I'm so glad to be here, and thank you to the organisers for their work to get me here. I'm going to make this stable. All right. So I think I've got a slide, but they're not really, I'm not going to use them. I will get it to the slide that I want though. All right, so there's just some words up there to have a look at if you want. So thank you to the organisers, especially for the generous invitation and the work to get me here, and thank you for those introductions. Indeed, my name's Sione, and I was born in Auckland, and my whakapapa goes back to Tonga, to Nukunuku village in Tonga, and also to Cornwall in England. And I've been searching around for a home for many years through my life, and I'm going to talk a little bit about how I ended up in the place I am. So I work at Harm Reduction Victoria, which is a drug user organisation in Australia, and it's one of 8 or 9 of those. There's state-based ones, and then there's a national one called AVIL. And we all came about from around about the HIV epidemic, which Harold referred to as well, when the governments couldn't figure out a way to deal with HIV, and one of the only ways, as Harold said, was for people who use drugs, for sex workers, for men who have sex with men, to actually be recognised and given some dignity to actually work with our own communities to try and prevent HIV. And so, Harm Reduction Victoria comes from that place. And so we're a drug user organisation. We're made up of people who use drugs, and that would include me. And we're funded by the government. And when I first got here on Tuesday, I was walking around Wellington streets, and it took me back really clearly to the times that I was getting around this town, using and injecting drugs, and I spent I guess a year or so in this town, and they were very precarious times for me then, trying to get money together, trying to find a dealer, trying to get some tech, whatever the things I was trying to get to. But it was also, it made me think about the crew of people that I actually hung out with, and the fact that we looked after each other and we were actually a community. And it reminded me that many of the things which made my life better and healthier were usually actually communicated to me by people who use drugs, not by health services. Why did I go to the needle exchange for clean syringes? Because it was the culture among my friends that we didn't pass Hep C on to each other. Why do we use wheel filters to filter out the plant matter from poppies that we stole? Well, because we were told about them by the people who use drugs, and they helped us stop infections. And it felt better. The drugs just felt better. Where did I learn that an overdose doesn't have to mean death? That we can breathe for someone for a long time if we take it in turns and don't run away in fear from the police and the ambulance? By people who had seen all of that before. By people inside the world of drug use, not by outsiders. When I went to the needle exchange, I saw people who I recognised as my friends there. They gave me clean syringes, even though the system demanded that we return 5 syringes to get 1 free, which is crazy. Sometimes we'd fill a returns container with old pens or sticks, and pretend, oh, here we go, here's enough syringes, and everyone knew, but of course, the clean syringes were the most important things, and the people at the exchange knew that. And they didn't call us on it. Although there might have been some in the background, I don't remember any of these health needs being met by a health system. They were met by people who use drugs despite their lives being criminalised and living without dignity, as Harold spoke about. So as I walked around Wellington, the other thing that I thought about was how much I'd missed out by not being here in Aotearoa for so long. I thought about, why did I stay over there in Australia? Well, there's many reasons, but for many years it's really been because of the peer drug user organisations, and that's where I found my place. I was able to be part of meeting the actual health needs of people who use and inject drugs, and not just what other people think we need on our behalf. I found empowerment. I recall the day I went for an interview at a drug user organisation and realised the fact that I was a drug user was a positive and not a negative for them. And on that day my life turned around, I think. These organisations were made up by people with lived experience of drug use, including current, and they were part of a funded response. Since then I've done a lot of different work in the space, but so much of it is related to improving access to healthcare and meeting unmet needs for people who use drugs, and reducing the barriers that criminalisation and stigma raise. 2 things that I've seen over and over again that many people can't believe if they're outside of the drug world is that people who use drugs are often very community minded, and also that will care about our health when we're able to. To give you an example of this, at Harm Reduction Victoria, we've got a program called the Peer Networker Program. Like a lot of what we do, it wasn't funded by anyone. We just saw a community doing something and tried to support it. So thanks to that renowned left-winger, John Howard, in Australia, his government commissioned a return on investment document in 2002 and 2009, and it found that the Needlands Fringe program in Australia, which is a program and not an exchange, by the way, had saved $4 for every dollar invested into the Needlands Fringe programs. It saved $4 in HIV and Hep C testing. And it also found that when you extended that beyond just a horizon of a few years and then started putting in things like opening doors to mental health, skin infections, and things like that, that return balloons to $12 per dollar invested. So it's worth it, even if you just want to save some money. Harm reduction and harm reduction that honours people who use drugs actually saves money as well. So the Peer Networker program is all about engaging with people who already collect 4, 5, 300, 600 syringes from the Needlands Fringe program and hand them out to their friends. And what we do is we meet with those people and then we developed a project with those people that actually paid those community peer outreaches for their data. So we asked them, who are you giving them to? What are their demographics and all that kind of stuff, and skilled them up and learned them up about all that sort of stuff. And we also paid them for that data, like I said, so that every month they would send in some data sheets for us, and then we'd put them into a spreadsheet and work out from our perspective what was going on in their communities. And what we found is those people were reaching at much higher rates the communities who were not reached by mainstream or Needlands Fringe programs run by health services, because we and they are those communities. In particular, women, LGBTQ plus people, Aboriginal people, and people who use methamphetamine were the communities who Needlands Fringe programs traditionally don't meet the needs of very well, and this community peer program was much better at reaching those people. The thing is, this wasn't done for payment or profit. This is an activity already in place which we then sustained through support and community development. We've got lots and lots of examples of people who are put on the rubbish pile who are being more generous and open-hearted than those who have got more to give. One quick more story. We've got a phone line called PAMS, which helps match people who want to get onto pharmacotherapy, match them with a doctor or a prescriber, opioid agonist treatment, I mean. And in this example, let's call her Sharon. Sharon had been prescribed opioid painkillers for severe pain following a car crash. She'd never ever taken an illicit drug in her life. Sharon built up a tolerance and dependence on opioids, and at a certain point her GP began to try and take her down off that pain relief. Funny enough, she was still in chronic pain and had a dependence, so of course she set about trying to find other places to get painkillers. And in that small regional town, she went and saw a few GPs. Most of them said, here's a script, take this, go away, never come back. Until basically she ran out of doctors, and at that point, after her original GP stopped prescribing and all the others had told her not to come back, what a surprise, she started purchasing it on the black market and the criminal market, and then this opened up her eyes to heroin as well. So she started buying and injecting hammer or heroin because it was easier than opioid painkillers for her to find. And you know what? It was her heroin dealer who was the first person to tell Sharon about methadone, about opioid agonist treatment, and to give her Pam's phone number, our phone number. Any one of those GPs who wrote a script could have given her, who wrote her a script, could have also written her a prescription for opioid agonist treatment, or referred her to a pharmacotherapy program, or told her about OST. Instead, they just wanted to get her out of their office and not have to deal with her any further. Instead, they just saw her as someone engaging in drug-seeking behaviour, basically. She sure was, for a really good reason in her case, because that was actually what she needed the most at that point in time. The only person who actually tried to meet her unmet health needs was a heroin dealer and an organisation of peers. And, to me, unfortunately, that's one of we see that sort of thing over and over again in the work that we do, is that our community are the ones who want to jump up and help our community immediately. And although there are some fantastic health workers out there, of course, too often the mainstream and across society, we're thrown on that rubbish bin, when actually we've got so much to offer. So today, as we talk about the unmet health needs for people who use drugs, we've got to remember as well that for many of us, one of the most important needs is to not be criminalised. So because I work in a supportive environment that I respect, and because I've been able to access a pharmacotherapy system myself, so I'm on methadone, I'm able to be fulfilled and actually still use drugs regularly. To me, it's a peek into an alternative future where people who use drugs are not criminalised and where drugs aren't just considered to just be a scourge that has to be eliminated, but in fact a part of a human experience. It doesn't mean that everyone's going to then run around using drugs. It doesn't mean there were no dependencies or issues. But it would mean that when people want or need help, they might be more inclined to actually step forward earlier and ask for help. The war on drugs, or prohibition as we know it, has failed completely to meet the most obvious health need of all, for people just to stay alive. It's been a war on drug users. Like many in this room, I've lost track or count of the people I've lost to overdose, early death through undiagnosed disease and cancer, liver disease, suicide. These deaths to me are directly or indirectly attributable to policies that our states, our politicians propagate, legislate and support. Like nearly every bad policy in our colonial systems, Indigenous people wear the worst of these policies, of course. So we have to be resilient and strong, but it's also true that many people in our community are traumatised, and sometimes that's intergenerational. So trauma-informed practice is important on an individual level, but for me also, at some point we have to have a look at our system and have a reckoning about the trauma on a societal level, about the needless pain and suffering that's been caused by policies that can't just be nibbled away at piecemeal, in my opinion. There was a recent Victorian coroner report about the death of an Aboriginal woman in Victoria recently, which we talked about at the Harm Reduction Conference. And it is an awful summary of the ways that stigma and discrimination can actively and immediately kill people directly. I urge you to have a look at that if you have the stomach for it. Finally, I put up a Slido. I don't think I bothered with I'm not sure if we put up the Slido results, but that's a good result. I'm glad. The 17 people who don't think that people who are drug dependent require treatment, that's cool. I just wanted to kind of talk about the fact that if we're going to meet the needs of the majority of people who use drugs, we shouldn't be forcing people who don't want treatment onto treatment if they don't need or want it. And use myself as the example of someone who would probably be quite happy to be off methadone if they could possibly just use their heroin occasionally, if it wasn't part of a black market and it wasn't a completely an uncertain sort of supply. But for many, many people, we think about the fact that we need to treat people when actually really all they need to be is to be left alone, and for prohibition and criminalisation to just go away. Thank you.